want to know about PARP inhibitors. I'm Maggie Nicholas Alexander, the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, metastatic breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Moore finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and it will be available on the SHARE website soon. Now I'd like to introduce our speaker, who we're so excited to have join us today. Dr. Kathleen Moore is the Virginia Curley Cade Endowed Chair in Cancer Development and Associate Professor of Gynecologic Oncology in the Department of Obstetrics and Gynecology at the University of Oklahoma Health Sciences Center. She currently serves as the Associate Director of Clinical Research and the Director of the Oklahoma TSET Phase 1 program at the Stephenson Cancer Center. She also serves as the Program Director of the Gyn Oncology Fellowship Program in the section of Gyn Oncology of the Department of OB-GYN. Her primary areas of interest are in new drug development and Phase 1 clinical trials. We're so excited to have you here today, Dr. Moore, and I'm going to hand it over to you now.
All right, great. Thank you for that lovely introduction. I'm going to share my screen. So if you can just let me know that you can see it okay. We good?
Looks good.
Great. All right. Well, I don't know if I'm going to tell you everything you need to know about PARP inhibitors, because we're still learning. I feel like we learn every day. But I am going to take you through sort of kind of the standard of care now and into the next year or so for frontline ovarian cancer, and a little bit about the recurrent setting as pertains to PARP inhibitors. And then I can answer some questions. So I always put this up. I work in Phase 1 and I do a lot of drug development. So I work with a lot of pharmaceutical companies to develop drugs for women with gynecologic cancers. And it's just important that you see, I work with everyone. Not super selective. If you're interested in developing in GYN, I'm going to work with you and try and see if I can move things into the space. So today we're really going to talk about mostly frontline, but I'm going to talk some about the recurrent settings. I think that's important as really pertains to what is going to be an emerging group of women who have already been exposed to PARP inhibitors, and what if their cancer comes back? Kind of what do we do then? So that's an emerging group and will continue to be so. But I think, to start with, there's actually a lot to be proud of. I finished fellowship in gynecologic oncology in 2007, which is increasingly a long time ago. And really, the decisions around how to take care of women with advanced ovarian cancer at that time and in the first years of my practice were pretty easy. We tried to operate on everybody, irrespective of how much tumor there was. And we gave everyone paclitaxel carboplatin, and then we saw what happened. That was it. And it's gotten much, much more complex as we try to individualize decisions about therapeutics as well as surgery for women who present with advanced ovarian cancer. And so there's quite a bit more data-driven decisions around, who should go to the operating room right off the bat, who should get chemotherapy first. And that's based on comorbidities, fitness for surgery, but also kind of disease-related criteria as well. We are much more aware of the differences in the histology of the tumors. Again, when I was a fellow, when I was in training, ovarian cancer was ovarian cancer, and they all went on the same studies, which is probably why we were not making inroads, because high-grade serous ovarian cancer is very different than low-grade serous ovarian cancer, is very different than clear cell, is entirely different than mucinous. These are entirely different diseases, even though they may have started in the ovary or the fallopian tube in the case of high-grade serous. And so they really warrant their own clinical trials and their own directed therapies. And we're increasingly incorporating that. And you'll see that in the studies I'm going to present. Stage is important. But then the other thing that's important really is the genetic and the genomic profile. Now, the genetic profile for women with ovarian cancer or the understanding that we should be testing for at least BRCA1 and 2, but now there's a panel of high penetrance genes that we are looking for. That's been known for a long time. We just weren't good at it. And that's just the truth. We've known that we should be testing basically all women with ovarian cancer for many, many years, and we just weren't good at it. And so a lot of women, unfortunately, have passed away without being tested, and their families are still at risk. The guidelines for testing for germline mutations related to ovarian cancer is just that. If you have a patient with a epithelial ovarian cancer, they should be offered their testing. There's no age or family history or histology criteria. It's that simple. It should be offered so that we can identify women who have BRCA1 or 2 associated cancers, also PALB2, BRIP1, RAD51C, and there are others emerging, because it does impact how we counsel you for subsequent maintenance therapy and even subsequent therapeutics. And it very importantly dictates how we offer testing and interventions to family members so that we can prevent cancers from ever happening in the family members of women with ovarian cancer, which is probably one of our highest, most urgent needs. So that's the germline testing. The other thing we've really developed, and this is more recent, is testing of the tumor. In some women, about 7%, they don't have a germline mutation in BRCA1 and 2, but you'll find it in the tumor. So they weren't born with it, and it doesn't get passed to kids, or it's not familial at all, but it imparts the same potential benefit of PARP inhibitors as we see in germline. And so we test the tumor for BRCA and other genes, although those are less frequent. And then we're increasingly testing the tumor for a sign that it struggles to fix its DNA, and that's called homologous recombination deficiency, HRD. Homologous recombination is the process by which all of our cells fix double-strand DNA breaks. And right now, you're sitting there and your cells are duplicating themselves, normal cells, and there's all sorts of errors happening. It's amazing we're all sitting here. But your body fixes them because it has this beautiful system of surveillance and repair. Homologous recombination is the most accurate way of fixing these double-strand breaks and kind of keeps us like upright and moving forward. So it's a really good thing if you're a normal cell to have intact homologous recombination, because then we kind of keep having normal cells. It's not a good thing if you're a cancer cell and you have intact homologous recombination, because it means you can fix your DNA. So when I give you things like carboplatin or a PARP inhibitor or gemcitabine or any of the drugs we use that hurt DNA, that tumor can fix it, and that makes them resistant. Fortunately, about 50% of tumors, at least at the beginning, have deficiency in this pathway. So they're homologous recombination deficient. We can identify them. It's not a perfect test. It needs to get better, but we can identify them pretty well. And that identifies a group of women for whom PARP inhibitors make more sense. And so we've gotten to a point where at the beginning, at diagnosis, we are doing a lot of profiling, or we should be doing a lot of profiling. And there'll be more to come with upcoming studies. So we can really make sure we're giving the right drug to the right patient at the right time. Now, so what's the big problem other than the obvious with ovarian cancer? Obviously, that it exists is the big problem. But what's the other big problem? Because the truth is, when you're talking about high-grade serous and probably high-grade endometrioid ovarian cancer, At diagnosis, these are exquisitely chemosensitive for most women, not all, but most. So with a combination of surgery and chemotherapy, most women will finish 6 to 8 cycles of chemotherapy with no evidence of disease on their CT scan and a normal CA-125. So the problem here is a couple. One is that that's not true for all women. And so what you can see on the left-hand side of this figure is what's called a Kaplan-Meier curve. And so this is basically every little dot on this curve is a woman who participated in a clinical trial. And every time the curve drops down, that's a woman who has progressed. So she's reached that end point, because that's the end point of clinical trials. And so if you look at, and hopefully you can see my cursor, if you look up here, this is just paclitaxel and carboplatin alone after surgery, very standard historical way we treat women. About 20% of tumors will recur within 6 months of finishing chemo. And that's not a good thing. That is called primary platinum resistance. And it just tells us that's a tumor that's really good at fixing its DNA, because it's just come right back. And we've done a lot of work trying to overcome that primary platinum resistance. And it's still a very high unmet need. So the fact that that exists, that's a big problem. The other big problem is that by 3 years, about 80% of women will have recurred. Now, there are a group who are cured. About 15% have long-term disease-free survival, long-term meaning out to 7 to 10 years. We don't quite know how to identify them, but they don't need anything more than paclitaxel and carboplatin. We can't identify them. But really, the vast majority of patients will recur by 3 years. And the good news is that we have many things that work for many, many years. But eventually, with time and exposure to many lines of therapy, these tumors figure out how to just be resistant to everything. So this development of chemotherapy resistance is a big problem. And so resistance leads to this. And so this is sort of the treatment course of a single patient. Just to give you an idea, is that with each line of therapy, once recurred, we still can have efficacy and we can still push out, time, good quality time for years. But each line of therapy, the benefit's a little shorter and the amount of tumor that's there is a little bit more. And there's residual toxicities. And so it just gets additive and additive and additive until such point that really you just can't treat anymore. The tumors are so resistant. And so the best opportunity we have to change this is to cure it in the front line. And that's what we're trying to do. And so the first big, I would call it a base hit, if you're a sports analogy, is Bevacizumab. You guys may know it as Avastin. This is a drug that isn't really a chemo, but it's an anti-cancer drug, and it targets how tumors make blood vessels for themselves. One of the many ways that tumors make blood vessels for themselves. And in ovarian cancer, at least high-grade serous and high-grade endometrioid, the cells give off this substance called vascular endothelial growth factor, or VEGF. And Avastin blocks that, or it sucks it up. And VEGF signals the body to create blood vessels for the tumor, and it also creates a very immunosuppressive environment around the tumor, i.e. your immune cells, if your immune system was going to fight your cancer, it just can't get in there. So VEGF is a bad thing. Avastin blocks VEGF, and it mixes well with chemo, and all sorts of things. And so we added VEGF to paclitaxel and carboplatin in the front line. These are 2 studies. They're a decade old now. And they were both positive. They improved the time, they lengthened the time to first recurrence in a meaningful way. We talk about a 20 to 30% reduction in the hazard of progression by addition of bevacizumab. And so this was important. It didn't improve overall survival, but it is an important adjunct for people to consider. I don't think it's a must-have, but it's definitely something to consider. Now, both of these studies stopped the drug about a year after chemo. It's just the design of the study. And one question that came up was, well, was that the wrong thing to do? Like maybe we should just continue it forever. If 80% of women recur by 3 years, we'll just keep it going so that they don't recur. And there was some rationale to that thought, in that when you looked at, these are all these same Kaplan-Meier curves, like I showed you, from a variety of studies, all of which used bevacizumab with Avastin with chemo, and for a set amount of time. And we say that they had what's called the banana sign, meaning when you stopped the bevacizumab, the separation of the two curves came back together and formed a banana. And so if you didn't stop the bevacizumab, would the curves stay apart and women who got bevacizumab do better? And so this was just presented this year, so I'm showing it to you. This was designed in 2010 when those two studies came out, and everyone said, well, you guys stopped the Avastin too early. You should have kept it going, use it forever. And so that's what this study is called. The BOOST study said, well, we're going to give it for a year, 15 cycles, or we're going to give it for 30 cycles. And I bet people will do better. Women will do better. Well, they did not at all. There was no signal that it helped one iota in either time to first recurrence or in overall survival. So this was somewhat disappointing. This just was presented. The study's been in follow-up for years, and we were all just waiting and excited about it and ready to change our practice. And it basically says no. So sometimes negative studies are very important, because if you were an early adopter of this Avastin forever idea, you should stop, because there is toxicity associated with it. It can be hard on kidneys, it can cause blood pressure issues, blood clots, etc. And so if there's no benefit beyond 15 months or 15 cycles, we should stop. And so that was disappointing, but that's why you do trials, so you don't do foolish things to patients. So really the big kind of more, I hope, home run, I don't know if we can say home run just yet, maybe a triple, is PARP inhibitors. And so if you think about approvals for drugs in ovarian cancer since 2014, every single approval, new approval for ovarian cancer has either been a PARP inhibitor or a PARP inhibitor containing regimen. Like, this really has been the future. So let's talk about what PARP inhibitors are, just so that everyone is kind of on the same page. I know you've heard about PARP inhibitors. We prescribe PARP inhibitors, but what are they? And so this is just a kind of a cartoon to show you that each type of DNA damage, I talked to you about double strand breaks, and you can see those kind of here, but there's a lot of ways DNA gets broken by either replicating or things we do to it, radiation, sunlight, etc. So each type of damage, and you can see the different types here, is repaired by a separate process, a specific process that involves a bunch of different proteins. BRCA is one of those proteins. And so, for example, if you look at here, this is DNA single strand breaks are repaired by what's called the base excision repair pathway. And so because DNA double strand breaks are potentially so lethal to the cell, there are multiple pathways that have evolved to deal with this. And these include things called non-homologous end joining, which you see on the right-hand side. This is a very error-prone way to fix DNA, but it can be used if the homologous recombination pathway is inactive. And then often that's so error prone that it leads to cell death. And so if we have a cell that has lost its double strand repair through homologous recombination, and it goes into non-homologous end joining, that can fix it, but it's so error prone, the cell often dies. So that's a good thing for our cells, for cancer cells, we want them to die. So how does PARP work here? So PARP is a protein, poly-ADP ribose polymerase, PARP. So PARP helps with single strand break repair. So here's a little cartoon. So PARP protein says, hey, there's a break. I'm going to bind here like a stick of gum. Then I'm going to recruit in a whole bunch of protein. I'm going to use some energy called NAD. I'm going to form chains of chromatin in order to open up the chromatin structure, which is a protein, and allow access to the repair proteins to come in and fix the DNA. So this is what you see with the PARP. It's made a little scaffold, like on the side of a building. And then these other repair proteins that you see here can come in and bind, and they fix that break. The PARP protein has to dissociate in order for this to work. It can't get stuck there, and then it gets recycled by something called PARG. So when you have a PARP inhibitor, so here's olaparib is one example, and olaparib's in yellow. You can see in the PARP proteins in purple. So the PARP protein binds to the single strand break, and it's trying to do its thing and make its scaffolding so the protein can come in and fix the break. But then you get a PARP inhibitor, and it comes and sticks itself to the PARP protein. And so the PARP protein, A, can't make its scaffolding, and B, it can't unpop from the DNA strand. So it kind of sticks it there like a wad of gum. And then when the DNA chain is coming along and trying to fix itself, this is called the replication fork, it just runs into this glom of PARP and PARP inhibitor, and the whole thing falls apart. So that's how PARP inhibitors work in a nutshell. There's a lot of other ways, but that's kind of how they work. So in a cell that already has trouble fixing its DNA, like a cell that's lost its BRCA protein, or other proteins, or the variety of ways that cells become homologous recombination deficient. This is about 50% of ovarian cancer. If they've already struggled to fix their DNA, and then I give them a PARP inhibitor, it's taking like 2 legs out of a 3-legged stool. It can't fix itself with the 3rd leg, and the whole cell dies. Now, if the cell is really good at fixing its DNA, meaning it's homologous recombination proficient, which the other half of cells are, then the PARP inhibitor, at least by itself, may not work really well. And I'll show you some examples of combinations that may be helping that work better. But there has to be some inherent vulnerability of the cancer cell already to fixing its DNA. Like it's struggling to do it, but it's just getting by. And then you throw this PARP inhibitor on, and it just kind of all falls apart. And so that's how PARP inhibitors work and why they're so interesting in ovary, where again, we have 50% of patients, tumors, who have this deficiency. And so we move this into clinical trials, PARP inhibitors, in a variety of settings, but eventually ended up in frontline. So this is the SOLO-1 study that I had the great privilege of leading with Paul D. Silvestro from Brown. And I'll remind you, it enrolled in 2013. So even though we presented it in 2018, it's a relatively old study now. We would have designed it differently now. Be that as it may, it was still awesome. So this took patients, women who had BRCA-associated ovarian cancer, advanced disease, and had gotten chemo and surgery and were in response to that. And the standard of care at that time was observation. We watched you for hopefully a long time, but sometimes not, to do maintenance or to do surveillance and watch you, until such point that the tumor came back. So that was the standard of care. So one arm was a placebo, and that was ethical at the time, not anymore. And one arm was olaparib. And we followed patients until they progressed, or if they had toxicity, or until 2 years. And at 2 years, we stopped the assigned therapy, either olaparib or placebo, which was the right decision. But I'll tell you, at the time, I was like, we should just use it forever, kind of like Avastin, but we would have been wrong. And so these were the results. And you can't really see, and hopefully you can see on the big screen, the placebo arm is in light blue, and the women who are randomized to olaparib are in maroon. And so this shows you the first half of the Kaplan-Meier curve out to the 2-year mark. This is where we stopped therapy. So there's a couple of things I want you to notice. These are all women with germline BRCA-associated cancers. And so at the time of this, there was this mythology that all of these women were cured because they were so sensitive to chemo and they did not need all of this maintenance, and we were over-treating them. That was the thought. And this placebo group tells you that that's nonsense, and it really is. You still see 20% of women progressing within 6 months of finishing their chemotherapy, even though they're BRCA associated and should be super sensitive. So that was very surprising to me. I was not expecting to see that. And by 2 years, you have only 35% of women who are kind of in surveillance still without evidence of disease. So 65% have recurred. Compared to the group who received olaparib, where basically nobody recurred within the first 6 months. There was like 1 or 2 patients. It's less than 5%. And by the 2-year mark, we still have 74% of women without evidence of disease. So this is when the therapy was stopped. And we were all worried that we would stop it and everyone would start recurring. And that didn't happen. And so we have data now. We have data beyond 60 months, but I can only show you the 60-month data, where we have about 50% of women who were randomized to olaparib still without recurrence, as compared to only 20% of women. And these women in the placebo group may be cured. This may be the group that really, truly never needed any maintenance, and they may go on forever, and I hope they do and don't recur, but it's only 20% versus 50%. And you can see all the little dots clustered here are all women who are still ongoing. So there's a lot of women still here kind of moving forward into this kind of 6-year, 7-year without recurrence, without evidence of disease. So that's pretty exciting. We won't know whether or not we have cured women until we have like at least 7 years of follow-up. So that'll be 2023. So we have a couple more years to follow folks and really look at overall survival, but that would be a home run if we improve overall survival in this population. So I'm very excited about that. I think we did it, but we have to wait for the data. So this led to an approval in 2019, and that has gone global as is appropriate. I was very excited, but only for women with BRCA-associated cancers. And I told you that 50% of women have this homologous recombination deficiency. About 18% of those are BRCA germline, and unless 7% have it in the tumor. So like 24% have BRCA-associated cancers and would have qualified for olaparib. But then another 25%, couldn't get it, and they might have benefited. And so there were several studies done to address this. And the first one, they all presented at the same time. So I'm just going to present them in no particular order, but this is the PRIMA study. And this uses the PARP inhibitor niraparib. It's called Zejula. That's its commercial name. And it was a similar study to SOLO 1 in that it enrolled women with advanced high-grade serous or high-grade endometrioid, not clear cell, not mucinous, who had received chemotherapy with surgery and were in a response, either a complete response or a partial response to their chemotherapy. And then it randomized them to receive a placebo or niraparib here for 3 years. And then ultimately they said it could be indefinite. And instead of limiting it to patients with BRCA-associated cancers, they said anyone can come on. And they stratified it by homologous recombination deficiency. So the endpoints here were the time to progression for the whole group and the time to progression for those tumors that struggle to fix their DNA. And that includes BRCA, of course, but it also includes the patients that don't have BRCA, but their tumors struggle to fix their DNA and should be susceptible to PARP inhibitors. Now, PRIMA was a very selected population of patients who really have never honestly been included in a lot of clinical trials. Their clinical features were very high risk. So it was a lot of patients, women who had stage 4 cancer or who had so much cancer that they couldn't have a primary surgery. So 70% of the patients here had received neoadjuvant chemotherapy, and 30% of them still had some disease left at the end of their chemo, which is very high risk. It's not common. So this was a very clinically high risk group of women as compared to SOLO and the other studies I'm going to talk to you about, not of women, of tumors. Women aren't high risk, of course. But here are the results. So these are, again, these Kaplan-Meier curves, and you can see they look very different, right? You want to be in the upper curve. So this is the whole population, everybody, including those tumors that are homologous recombination proficient or good at fixing their DNA. They're in here too. And so you see about a 40% reduction in the hazard of progression if you use niraparib. And so that's pretty exciting. And then if you look at the group of tumors that are homologous recombination deficient, it's even better. So here you see almost a 60% reduction in the hazard of progression. So that's a really big improvement over placebo, which was the standard of care at this time for women following chemotherapy, and very rapidly became approved and a standard of care. Now, interestingly, niraparib is approved for all patients. You do not have to be BRCA, and your tumor doesn't have to have homologous recombination deficiency, because when they broke it down, you can see on the left-hand side here, these are the tumors with BRCA, and they do amazingly well with PARP as expected. In the middle are patients that do not have a BRCA mutation, but for other reasons, their tumors struggle to fix their DNA. And they do amazing, 50% reduction in the risk of progression. And then on the right, you see the group of tumors that by the test we use should be really good at fixing their DNA. And so you wouldn't expect them to benefit a ton from a PARP inhibitor, which works, like I talked to you about. But you did see this bump, it was about a 32% reduction in the hazard of progression. So it's not as big a benefit as BRCA or HRD, but it's still a benefit over placebo, which is why the FDA approved it for all women with advanced epithelial ovarian cancer. And so this drug is available as a monotherapy switch maintenance for everyone, irrespective of biomarker. Now, the third study that's important is PAOLA. And so PAOLA was done outside the United States. Outside the United States, in many countries, bevacizumab or Avastin is the standard of care in frontline. It's the only line they can use it. In the United States, we can use it kind of wherever we want to use it. But in many parts of the world, you get one opportunity to use Avastin, and it's with chemo in the frontline. And so they said, well, we're going to use it because we're not going to not use it, but we want to add PARP inhibitor to bevacizumab and prove that it works better. And so that's what the PAOLA study did, is very similar to the other two. All comers, you did not have to have a BRCA-associated cancer. You had to just be in response to your chemotherapy that included bevacizumab or Avastin. And then you were randomized to receive to continue the Avastin, they didn't take it away, plus a placebo, or to continue the Avastin plus olaparib. And they were looking at the time to progression. And so here's the results of this. Now, the other studies I showed you were compared to a placebo, right, to nothing. This is compared to a drug we know is active. Avastin is a good drug. So it's compared to an active control. In red, that's Avastin, and in blue is Avastin plus olaparib in all comers. And so this had about a 41% reduction in the hazard of progression. So that's very striking. And we were very excited about this. They did the same kind of breakdown as I showed you in the niraparib study. So on the left are the BRCA tumors. So they have a 70% reduction in the risk of progression. So that's amazing. In the middle are the tumors that do not have a BRCA mutation, but are HRD. So they have a 60% reduction in the hazard of progression. So that's amazing. But surprisingly here, when you look at the tumors that are homologous recombination proficient, they're good at fixing their DNA, there was no bump with the olaparib over bevacizumab, over Avastin. So Avastin worked pretty well in this group, and you didn't bump any more with the olaparib. And so because of that, the FDA only approved this combination for women that have homologous recombination deficient tumors, inclusive of a BRCA-associated cancer. So that's where we live now. In Brazil, they can use it in anyone. The global approvals differ, but in the US, we're limited to this label. So we have these 3 approvals. And so what does that mean for you? So we can do it by biomarker. So if you have a patient, or you're a patient with newly diagnosed ovarian cancer and you have a BRCA-associated cancer, either you're born with a BRCA mutation or your tumor has one, do you just get chemo and olaparib alone, or niraparib is fine too, like monotherapy PARP inhibitor, or should you add Avastin or bevacizumab and get both? That's the question. And so it's hard to know because the PAOLA study that I just told you didn't have an olaparib alone arm. So you don't really know. So both of them are amazing, honestly. So we did this little analysis, and you can see on the right, we did this little mathematical analysis. This isn't a real clinical trial, but we took the patients who received bevacizumab and olaparib on PAOLA that had a BRCA-associated cancer, pulled them out. And then we went back to the SOLO-1 population, and we took a group of patients who got olaparib that clinically looked like the patients on PAOLA. So we tried to match and recreate the missing arm in PAOLA so we could compare. And that's what you see here. So this is a mathematical exercise, but it's helpful to providers. Honestly, we do make decisions kind of based on this, in that the green is both drugs and the orange is olaparib alone. So there's a little bump with both in a patient with a BRCA-associated cancer. It's about a 29% improvement in the progression-free survival. It looks what we call additive. So it's not synergistic. Like when you put them together in this population, in a patient population with BRCA, they don't like make each other work better. They just are adding together each individual component. And so really what we tell providers is, if you like to use Avastin or bevacizumab, use it, and then just add olaparib to it. If you commonly don't use it, or you don't think your patient needs it, and they have a BRCA-associated cancer, it's okay to use olaparib monotherapy or niraparib monotherapy. That's fine too. So it really dissociates the two from one another because we don't think they're synergistic in this particular population. So you can use one or the other based on clinical features. Now, we don't have the opportunity to do that fun little math in patients who are BRCA, don't have BRCA, but their tumors have homologous recombination deficiency for other reasons, because the PRIMA study is so different in its population than PAOLA that we can't pull patients out and make them look like one another. So we can't do that. So really you just have, this is the data for patients who are BRCA negative, but HRD positive. And there may be synergy here based on some studies that have been done in the recurrent setting. I'm very interested in that. So in this population, I actually do favor the combination based on no data, just my gestalt. And I really want one of the drug companies to do this clinical trial in BRCA negative, HRD positive, PARP alone versus PARP Avastin. I think we need to do that study. But right now, you kind of do the same thing. If a provider thinks bevacizumab makes sense, you should use it. And if you have an HRD positive tumor, you can add in PARP on top of it. If you don't think bevacizumab makes sense, you can still use the PARP, and that's just fine. So you dissociate the two drugs from one another. But in the future, if we prove they're synergistic, we may be stronger about using them together, but we don't have data for that yet. Now, the biggest unmet need, in my opinion, there's two, is for patients whose tumors are really good at fixing their DNA, this homologous recombination proficient group. And you can see them out here. The niraparib does work pretty well here, and I think is an option. And also Avastin or bevacizumab works pretty well here. But really, these Kaplan-Meier curves look very different. They're much more vertical than these, and certainly than these. The flatter the curve, the better the patients are doing. And so when you have kind of a vertical curve like this, every time the curve goes down, it means another woman is progressing. So these are high-risk tumors, and we need to really focus on how to combat them with drugs that target why they're not responding to DNA, which is probably, or DNA damage agents. It's probably not a PARP. It may be something else. So we're thinking that maybe immunotherapy would work here. And I have so many patients that come in and they're like, I really want immunotherapy. It seems so exciting. And I see all the commercials and I want to try it. And so did we. And so we did 2 big clinical trials, big trials, thousands of women, incorporating immune checkpoint inhibitors, which are approved for other tumors, melanoma, lung, bladder. These are commonly used drugs. And we gave them with chemotherapy and to follow as a maintenance in ovarian cancer. And these studies were just relatively recently presented. And both of them were entirely negative. Absolutely no benefit in any subgroup, in any person, no signal of benefit for immune checkpoint inhibitors. So it doesn't mean that immunotherapy won't work. There are many types of immunotherapies, and we're looking at them actively in women who have mostly recurrent ovarian cancers, but there's a few clinical trials coming where they're incorporating novel immunotherapies into frontline. I can't show you those yet because it's not quite in the public domain. But things like Keytruda and Opdivo, Imfinzi are great drugs for many solid tumors. They really are, but not for ovary as monotherapy. They just didn't work. And so we kind of are back to the drawing board. So in terms of what's kind of coming and is exciting, this is, I know, a busy slide, and it's a small study, but it was performed, it enrolled women with recurrent cancer, ovarian cancer, that was considered sensitive to platinum, meaning they didn't recur within 6 months of finishing their chemo, and they may have recurred a long time after that. And they were offered a non-chemo option of a PARP inhibitor with an immune therapy, with or without Avastin, bevacizumab. And this study was done before. And what you see here are what are called waterfall plots. And so the bars that are below the line are tumor shrinking. And the longer the bar means like more tumor shrinkage. So if the bar goes all the way to the bottom, that meant all the tumor went away. And so it's the percentage of the tumor that gets smaller. And if the bar goes up, it means the tumor grew. So you can see on the left for the women that got PARP inhibitor, immunotherapy, and Avastin, most women responded and responded really well. Even more interestingly, if you look at the bottom table, LOH means loss of heterozygosity. That's another word for HRD. So LOH positive means it's a homologous recombination deficient tumor. Well, 100% of those patients' tumors responded, which you'd expect with a PARP. And the next one then that I have the red bar is those that are homologous recombination proficient, where I just showed you PARPs don't work all that well by themselves. But here, 75% of tumors responded. So that's interesting. It's a small study and it may be spurious, but I'm interested in this. So, so these are the studies that are done, big studies in the front line, thousands of women accrued. All of these studies are completed and we're waiting for the results. We probably won't hear until late 2022. But all three of these studies that I've highlighted in red have that triplet of a PARP, an immune therapy, and Avastin or Bevacizumab. And they all allowed women to come on irrespective of their homologous recombination status. So we're going to have a lot of women whose tumors are homologous recombination proficient in order to see if this is real, this triplet maintenance. Because if I'm going to use triplet maintenance in someone for 2 years, it better work, because that's a lot of stuff to put someone on, you know, when they're supposed to be disease-free and feeling good. But if it really does improve their outcomes, then it would be worth it. So I think this is something to keep an eye on as we move forward. But again, we won't hear the first results of these probably till late 2022, and that'll be the first study. The first report should be the first study, which is the first one. I didn't mean to do that. So now we're using PARP inhibitors in the front line, basically in everyone. And a lot of women are getting Avastin or Bevacizumab, and we might get immunotherapy, we'll see. And hopefully that cures more women, right? That has to work. Some increased fraction of women have to be cured. But unfortunately, some are still going to recur. And so if we've used all our best drugs up front, what do we do when they recur? What happens here? And so this is really the other high unmet need I was talking about. And here the data is just starting to come. This study should result any day. This is called the Oreo study, which is kind of fun to say. And basically it asks the very unsexy question of, if you have already received a PARP inhibitor and you recur and get platinum again, carboplatin and Doxil or gemcitabine or Taxol, and respond, can you get PARP again? And will it help you again in the maintenance setting if you've already had it? We know in the platinum sensitive setting, if you respond to your platinum and you get a PARP, we know it's going to work in a PARP naive population. But in a pre-treated, PARP pre-treated population, does reuse of PARP make sense? That's what this study is asking. And it's not like super sexy, as we like to say, but it's super important because a lot of us are doing this. If I don't have something to use for you in maintenance, I mean, I know what's going to happen if I don't give you anything. So I've been reusing a PARP inhibitor. A lot of us are with no data. And again, we may be proud of ourselves for being so forward thinking when this results, or we may be like, ooh, I got to stop the nonsense, you know, because I'm just harming people. So this will be a very important study and should report anytime. The other big high unmet need is really, you know, if you've had a PARP and your tumor grows on the PARP, like you're on it and you start growing, can we reverse that? Or can we overcome that? And this is where a lot of the trials are. And I'm not going to go into too much detail. I just want to show you the amount of work that's being done right now and active clinical trials that are enrolling to try and figure this out. One of the big things is reversion mutations. And so these are just emerging. We're just learning about these. And Liz Swisher and her team from the University of Washington has really led a lot of this development through the rucaparib program, where they've looked at a blood test, circulating test. They don't even have to do a biopsy. And they look for basically in a patient with recurrent ovarian cancer who's seen chemo, no PARP, just seen chemo, and they have a BRCA mutation, something can fix the mutation. And I'll show you that in a moment. So that instead of having a loss of that BRCA protein, which is what makes the tumor susceptible to carboplatin and PARP inhibitors, because you don't have that BRCA protein, which fixes the DNA. If you fix the genetic mutation and you have a normal protein, all of a sudden your now resistant to PARP inhibitors and probably carboplatin. So this happens. And on the rucaparib program, they found that in patients who even had never had a PARP, if they identified a reversion mutation, they did not respond to the PARP inhibitor at all. And so this is something and it's not a commercial test yet, so we can't test for this yet, but it's coming. So this will be incredibly important in the future if I'm considering a PARP inhibitor in someone in the recurrent setting, even if they've had it before, say Oreo says it works, I want to know this data because I'm probably not going to use monotherapy PARP. It's going to waste your time. Or I'm going to use what's in this paper. And this is a fabulous paper. I know this is a complicated slide, but it just goes into these reversion mutations. They're really complex and they're caused by exposure to PARP and they're caused by exposure to chemo. And the type of exposure may dictate how the mutation was fixed. And that may dictate the strategies we use to overcome it. So for example, there are certain mutations that are mediated by this MMEJ pathway, and those may be amenable to what are called pol theta inhibitors. Sorry about that, I mean to roll. And those pol theta inhibitors have just entered the clinic. So that's very exciting. So can we prevent them from happening, or can we introduce a pol theta if someone's starting to progress on a PARP? We don't know the answer to this yet, but this is what's coming into trials. So we can try and help women who develop these reversion mutations maintain their sensitivity to chemo. So that's really important. There's a ton of other ways that tumors figure out how to fix their DNA. Even in the setting of BRCA or HRD, they upregulate all these other pathways. I mentioned to you VEGF around Avastin. That's one pathway that can get upregulated and restore how tumors fix their DNA. So Stephanie LaRue from Princess Margaret in Canada, she's super smart, said, well, maybe I can overcome PARP resistance by adding an anti-VEGF drug to PARP in women whose tumors grew while they were getting a PARP. So she added not Avastin, but a drug called Cediranib, which is an oral drug that works differently, but still targets VEGF, and tried to overcome the resistance. Well, what she found is it didn't work, number one. And number two, these women were very brave who went on this study and they all got biopsies. And she learned the myriad of pathways that made the tumor resistant. It's not one thing. It's not even 10 things. It's a whole myriad of things that makes these tumors resistant. So we have our work cut out for us really understanding how we're going to individualize these combinations for women whose tumors have stopped responding to PARP, because we just can't throw things at you, and hope that it works. With this complexity of what's happening in the tumor, we have to have some way of understanding what's wrong in your tumor so we can give you the right combination. And those studies are happening now. And this is just a couple examples of them. This is combining olaparib, a PARP inhibitor, with what's called a PI3 kinase inhibitor. PI3 kinase inhibitors increase the BRCA-ness of a tumor. They make the tumor unable to fix its DNA, which is not something we understood well for a long time, but now we do. And Panos Konstantinopoulos is leading the study called EPIC-O. This is open now in the United States with a PI3 kinase inhibitor and a PARP inhibitor. It allows patients who've had prior PARP inhibitors, but then he has this study coming through the NCI that is only for women whose tumors are resistant to PARP, combining a PARP inhibitor and a PI3 kinase inhibitor. Very important study. And the other way we're trying to come at this is with combinations that attract, remember I showed you when the PARP inhibitor binds to the PARP and then that replication fork comes, it can't get by the wad of gum. And so if you hit that replication fork in different ways, even if your tumor's figured out how to fix its DNA and it's restored that homologous recombination proficiency, if you hit that replication fork, which still relies on PARP, you can still cause kind of this synthetic lethality. And so we're targeting that with ATR inhibitors. So this is very small data that Stephanie Wethington and Fiona Simpkins have done out of Hopkins and Penn in patients whose tumors are resistant to PARP, and they've given them both drugs back, this AKT or ATR inhibitor and a PARP, and you see these responses. It's a waterfall plot. It's small, but this is promising. And then Shannon Weston at MD Anderson using a WEE1 kinase inhibitor, also in that replication fork pathway, also in women whose tumors are done responding to PARP. And she has response rates in the BRCA tumors that are okay, 20%. Meh, that's okay. But in the BRCA, non-BRCA tumors, 30% with the WEE1 alone, 40% with the combination in a recurrent platinum resistant and PARP resistant setting is a very nice signal with 94% clinical benefit rate. This needs to move into a bigger trial, and she's working on that right now. So that's pretty exciting. So I think there's a lot of things coming. There's way more things I could even talk about. So these are all entering the clinics. A lot of them require biopsies because we're really trying to match mechanisms of resistance for a person to a trial. Very complex, but I do think we're going to get there. And there's a lot of new drugs entering, even that more than I've talked about, that may even be more important in this setting. So I think the bottom line is we're really trying to cure more in the front line until we can screen. And then for those women who recur, really trying to develop individualized therapies that target the mechanisms that are off in their particular tumors, so we can really, again, give the right drug or drugs to each individual person at the right time to prolong life, which is what we're trying to do. So with that, I thank you for your attention. I'm happy to answer questions. This is my dog.
Adorable dog. Thank you so much, Dr. Moore. That presentation covered a ton of ground, and I'm sure we'll have some questions. So let's start the Q&A. Everyone can still submit your questions in the Q&A section at the bottom of your screen. We'll try to get to as many of the submitted questions as possible, but we may not be able to due to time constraints. So the first question, and we get this a lot, is really around like how long is the recommended course of treatment for PARP inhibitors? Like what duration can people be on? And similarly, like some people were asking about continuing past 3 years. So I wondered if you could sort of address like how long people should be on the PARPs and in what situations.
Yeah, I'm looking at that Q&A. There are quite a few questions on that. So I appreciate that question. You know, and I helped design SOLO-1, and I sat there and was like, we should use PARP for forever because, you know, so many patients recur, and why would we ever stop it? That's the dumbest thing ever. We shouldn't stop it. And the FDA wouldn't let us. And so we had to limit it somewhat arbitrarily to 2 years, but we were really trying to cover kind of 2 standard deviations from the expected average progression-free survival, which is 13 months, which is exactly what we saw in SOLO-1. And so we were covering that with the 2 years. So admittedly, it was somewhat arbitrary. What I will tell you is that when you look at the survival curves, and I think I can just like pull this back up. So if I look at if I pull up the survival curve for SOLO-1, what I will show you and how we think about this is, okay. That didn't work well. Sorry about that. If you have a migraine, don't look right now. Okay, here. So when the slopes of these curves become the same, so when the event rate that's happening in the women that were randomized to olaparib becomes the same as the event rate for women that were randomized to placebo, you have to question whether or not you're doing anything more for that group. So you can see the curves, the slope of the curves are very different in these two curves out to 12 months and really out to 24 months. It's actually about 18 months. And then the slope of the curves are almost identical from 2 years on. So the event rates become very much the same. And that tells us that we really don't think at that point there's any benefit. If the event rate in the olaparib arm is the same now as the event rate in a group of women who haven't received anything for 2 years, then are we really doing anything by adding something at that time period? which I know is sort of hard to say. It's like a statistical analysis, but we've done these exercises for all these curves across the PARP inhibitors. And we really feel like the benefit here for some women is an early effect. Now, I do think that we have to take that with a grain of salt. So in SOLO-1 is a very particular patient population. 44% of the patients were stage 3, not stage 4. They had primary surgery and they had no gross residual disease. So clinically, all ovarian cancer is high risk. I would never say they're low risk, but they're much lower risk than PRIMA, where it was stage 4 neoadjuvant. So these are groups of, and they're all BRCA. So this is a group of patients that started off largely with nothing we could see. And so for that group of women, when you're starting off with nothing you can see, you know you have some circulating tumor cells, but they're probably all the same. They're not heterogeneous yet. They haven't started changing. And then you hit it with a PARP, you may have wiped out that homogeneous clone, and that may translate into cure. And so you don't need 2 years to wipe that group out. You've probably done it in far less time, although I wouldn't risk it by giving less than 2 years. So in that group of patients, I think you stop at 2. If someone asked about a stage 2, I would definitely stop at 2. In PRIMA, in a patient who had stage 4 disease, much higher risk clinical features, someone that comes on a PARP and they still have evidence of disease, CA125, some peritoneal thickening, something like that, I would probably continue it beyond 2. And PRIMA is going to show us that, when they presented PRIMA, which is the niraparib study, they only had 18 months of follow-up. We have 60 months on SOLO-1. So it's a very different amount of data to learn from yet. But PRIMA, we're going to start seeing updated data on the length of time because they are allowing patients to treat forever. But that patient population is entirely different than SOLO. And so there may be different selections for length of time based on clinical features. That's something I'm really interested in thinking about. But in someone that's a PRIMA type clinical patient, I probably wouldn't stop. But in a SOLO type patient, PAOLA type patient, I'm going to stop at 2 years because the risk is of continuing forever is potentially setting someone up for PARP resistant disease. If you recur 6 years later, I'm probably going to use a PARP again. Hopefully I have something better by that point. If I treat you until you're resistant to PARP, then you're probably going to be resistant to platinum too, and I may be harming you down the road. So, it's sort of a balance of trying to cure people, and also not trying to set them up for resistances down the line. But it is a clinical question. There's some equipoise here.
So it sounds like it sort of depends on how their cancer presents and then also what PARP inhibitor they're on that determines how long they should be on it.
Well, the type of PARP, the PARPs are the PARPs. I think it's more the clinical features for me that would dictate, and of course toxicity and how they're tolerating it. But for all other things remaining equal, if you're stage 3, like I just did a debulking, I guess I can't say when because I don't want to identify the patient, but she had very low volume disease, was no ascites, low volume stage 3. I'm gonna give her IP chemo and I'm gonna give her 2 years of PARP. I would never consider like giving her much more PARP. She's not gonna need it. Like her clinical features are as great as they could be for an advanced stage ovarian cancer diagnosis, as opposed to the usual where there's so much bulky disease and they're so clinically high risk. I might consider using longer depending on how well they responded to the PARP. And I also think a difference BRCA versus non-BRCA. Non-BRCA is a higher risk for recurrence, in a shorter period of time. And so SOLO was just in BRCA. I'm going to use 2 years. And PRIMA, like HRD, certainly in HRP, I'm probably not going to stop it because the risk of recurrence is so much higher. So it's going to be individualized, I think, for the patients based on their molecular profile, their presenting clinical features, and how well they respond to their first chemotherapy. That gives us a sense of sort of how long someone should be on. But I wouldn't arbitrarily say 2 years for everyone. That's a different thing.
Okay, great. Thank you. And I'm looking at the time and I think we only have enough time for one more question. So I do A lot of people have questions about whether a PARP is for them. And so I'm just wondering if you could sort of talk about in what circumstances would you not consider a PARP for someone?
Yeah, that's a good question. The frontline setting, so someone asked this, if someone has recurred and their tumor is resistant to platinum and they do not have a BRCA associated cancer or another gene, I would, unless it's a clinical trial with a combo, I would not be looking at a PARP for them because the likelihood of a response is less than 5%. We've done those studies. So monotherapy PARP in that setting does not make sense to me. Now, if someone wants to try it, I'm going to tell them all the data. Sometimes we try things, but it's not what I would recommend. So in that setting, I wouldn't. In the front line, I think this is where it gets a little bit hard. I think PARP is the standard of care for BRCA maintenance. I think it is the standard of care for HRD maintenance. The hazard ratios that show the improvement are just too great to say there's any alternative, in my opinion. Homologous recombination proficient is tougher. I think it shows a benefit, but it's not outstanding. We don't know if PARP is equivalent to, less good, better than Bevacizumab, Avastin. And so I think they're both in play. And so in a patient who I'm going to use Bevacizumab, someone that's got a lot of ascites or very high risk features, and I've started Bevacizumab during their chemo, that's what I'm going to use at maintenance. And I'm probably not going to use niraparib there. And somebody else, I haven't used Bevacizumab, I'm a believer in maintenance, some aren't, then I would probably still try niraparib in that setting, even in a homologous recombination proficient tumor, because that may be the only opportunity to try a PARP. The other indications are platinum sensitive recurrent maintenance, which means you have to be platinum sensitive and then you have to respond again, and then you can get the maintenance. So I may not get a patient to that point and she may never have the opportunity to have a PARP. So you kind of have to weigh that in that setting. And it's a hard discussion, because you don't have a crystal ball to have with patients about how well they're going to do. So I wouldn't, in the front line, there's not anyone that I'd be like, I'm never using a PARP in you. It's just a decision based on the biomarkers and the patient, and what her priorities are.
Great. Thank you for that. And yeah, so thank you so much for being here today, Dr. Moore, and for such an informative program. And thanks to everyone who joined and participated today in this webinar. I hope that you will all please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and there will also be a link to the survey sent to you in a follow-up email, but we really use that to improve our programs and make sure what we're putting out is of interest to you. And the surveys are anonymous. So thank you again, everyone. And thank you, Dr. Moore, so much for being here today.
Thanks for having me. All right. Bye.
Bye.